Hello, my friends and my colleagues and my fans. I want to continue talking about the lung-kidney interaction in disease in clinical practice. And as I showed all of you, and as I mentioned, the relation between the kidney and the lungs in clinical practice, or the lungs and the kidney in clinical practice, is rather complicated and multidimensional, and it takes place in various ways. There is a mutual relationship between the two organs in health and disease. And since I am focusing on the relationship in disease, which reflects their interaction in health also, it's mandatory to say and to mention what's called the pulmonary renal syndrome. I already mentioned the effects of lung disease on the kidneys and the effects of renal disease on the lungs, the opposite way. And now I will talk about what we call the pulmonary renal syndrome. The pulmonary renal syndrome, it's actually a separate entity, but it's not a specific entity. It is rather a syndrome with various causes and with various pathologies and with various clinical presentations. That's why it's called syndrome, not a disease. To summarize the pulmonary renal syndrome, it is a syndrome with various manifestations related to the kidney and to the lungs, which might happen simultaneously at the same time, or their symptoms may take place apart, maybe weeks or months apart from each other. But we should think about this syndrome, the pulmonary renal syndrome, in any patient presenting with unexplained pulmonary and renal symptoms, which happen sequentially or simultaneously at the same time, or sequentially, that's with passage and progress of time, we observe the post-renal and pulmonary manifestation. That's whether they occur simultaneously or apart. It most probably is related to an autoimmune process in the body, which might be of type 2, that is cytotoxic antibody related, like what happens in Goodpasture syndrome, or it might be immune complex type 3, immune mediated, that is immune complex mediated reaction, like what happens in Wegener's granulomatosis, or the granulomatosis with polyangiitis. I will mention them. So whatever the type of immune reaction taking place, type 2, type 3, or type 4, there is an autoimmune disease. There might be some sort of vasculitis, or there might not be a vasculitic process. And if there is vasculitis, there is involvement of the small vessels. In this disease, in the pulmonary syndrome, there is involvement of the small vessels of the lungs, that is the pulmonary arterioles and the capillaries, with an inflammatory process which is immune mediated, causing alveolitis and resulting in lower respiratory manifestations, alveolar manifestations, that is manifestations due to alveolar disease, due to pathological involvement of the alveolar base membrane and the alveolar capillaries and the arterioles. And this will cause alveolar hemorrhages, which present as hemoptysis, cough and hemoptysis, and dyspnea, and chest discomfort, which are the main features, and renal manifestations due to involvement of the small vessels of the kidney, that is the glomerular capillaries and arterioles, and this will result in some sort of glomerulonephritis. So, and the glomerulonephritis will cause renal manifestations, whether microscopic findings or clinical features of acute glomerulonephritis and even acute nephritic syndrome with acute renal failure in some cases, if not treated. So there is alveolitis in this pulmonary renal syndrome. There is combined alveolitis and glomerulonephritis, which are immune mediated and which are related to pathological involvement of the small vessels of the alveoli of the lungs and the small vessels of the glomeruli of the kidney. So this is the pathogenesis of the pulmonary renal syndrome. And the common diseases which are associated with this autoimmune destruction in the lungs and in the kidney at the same time, in the alveoli and in the glomeruli. They are associated with common examples. Common causes are the good pasture syndrome. It is a typical example of pulmonary renal syndrome, good pasture, which is a disease associated with antiglomerular basement membrane antibodies and alveolar and anti-alveolar based membrane antibodies causing type 2, that is cytotoxic antibody. Usually there is linear immunofluorescence with IgG antibody, which destroys the alveolar based membrane and at the same time also destroys the glomerular based membrane and produce the clinical features of fever, hemoptysis, dyspnea, chest discomfort, and features of glomerulonephritis with microscopic hematuria and proteinuria and sometimes oliguria and renal failure and peripheral edema. So whenever we see features, clinical features of renal involvement with hematuria, proteinuria, and classic clinical picture of acute nephritic syndrome, which progress to even to oliguria and peripheral edema in some cases, oliguric renal failure and peripheral edema, together with pulmonary manifestations of hemoptysis, cough, hemoptysis, dyspnea, that is shortness of breath, which might occur at rest or with effort, and chest discomfort. But the most important is the cough and the hemoptysis due to alveolar hemorrhages. And the patient is usually feverish, fever. So this fever, pulmonary manifestations, think about pulmonary renal syndrome. Think about good pasture syndrome as a cause of pulmonary renal syndrome. Other causes of pulmonary renal other than good pasture is Wegener's granulomatosis. And we all know that Wegener's granulomatosis, its new name is granulomatosis with polyangiitis. And here there is a mixed pathology of non-caseating necrotizing granulomas involving the upper and lower respiratory tracts, together with segmental necrotizing glomerulonephritis involving the kidney. So there is necrotizing glomerulonephritis, which might present with crescentic glomerulonephritis and rapidly progressive glomerulonephritis, leading to rapid renal failure, acute renal failure in cases which are not properly treated, together with respiratory features, upper and lower. The most common upper is involvement of the nose with saddle nose deformity and rhinitis, stuffy nose, crusting nose, hemoptysis, also bleeding nose, bleeding from the nose due to nasal and nasal sinus involvement. And also involvement of the throat with tonsillitis, sore throat, involvement of the larynx, involvement of the trachea is common in Wegener's granulomatosis, and also involvement of the ears with impaired hearing, involvement of the eyes with scleritis, episcleritis, visual disturbances. These are also part of the Wegener's, but most common it involves the upper with saddle nose deformity due to nasal cartilage affection by granulomas, and then it involves the lower respiratory tract also with granulomatous, non-caseating granulomatous inflammation, with cavitation, with lung nodules, with cavities in the lungs, with infiltrates in the lungs. So it commonly involves the bronchi, not exactly the alveoli as in good pasture. In good pasture, the involvement is in the alveoli, but here it usually involves the bronchi and the respiratory acinus, that is the proximal respiratory acinus, the small bronchioles and bronchi with granulomas and with infiltrates, cavitations, and a picture of pneumonitis. This is the Wegener's in the respiratory tract. And then in the kidney, it will produce some sort of necrotizing segmental glomerulonephritis, which might present as rapidly progressive glomerulonephritis and acute renal failure. But before the renal failure, it might present with just milder findings of proteinuria and hematuria. So the renal manifestations as well as the pulmonary manifestations, they characterize Wegener's granulomatosis, or what we call granulomatosis with polyangiitis, which is another cause of the pulmonary renal syndrome, in addition to the good pasture syndrome. Other common causes of the pulmonary syndrome are the systemic lupus erythematosus, or the SLE, and also microscopic polyangiitis. Less common causes is the mixed connective tissue disease and leukocytoclastic dermatitis and the mixed, essential mixed cryoglobulinemia with involvement of the kidneys with glomerulonephritis, and at the same time involvement of the lungs with interstitial lung disease. These are all the causes of the common and less common causes of the pulmonary renal syndrome, but they all present with alveolar manifestations or manifestations due to alveolar pathology and renal manifestations due to glomerular pathology. The treatment is treatment of the autoimmune disease. The diagnosis, of course, depends on chest X-ray, depends on ultrasound, depends on urine examination for proteins, for red blood cells. We'll find hematuria, we'll find proteinuria. Serology to detect antibodies, to detect also the ANCA antibodies, the P-ANCA in patients with vigorous granulomatosis, and the anti-glomerular basement membrane antibodies and the anti-alveolar antibodies in patients with good pasture syndrome. Serology is important. Sometimes we need also biopsy from the lungs and the kidney to reach the definitive diagnosis, and ultrasound of the kidneys and chest X-ray for the lungs to detect any cavitations, infiltrates, etc. Treatment may be by steroids, by cyclophosphamide, by other immunomodulating agents. We may need also plasma exchange and other modalities of therapy for management of the autoimmune cause of the pulmonary renal syndrome. By this, I will end my short presentation about the pulmonary renal syndrome.